This is a video station on discussion of various conditions of abdominal presentations in the MRCPCH exam. So let's have a look what are the different cases that are discussed in this video. And so we'll just be talking about differential diagnosis and management because we will not go into the detailed examination of abdominal system. Uh, any examination, we will follow the same structure. Introduce the Viper thing, introduce yourself, wash, and then you look around the patient, look at the patient, how the patient is looking, well, unwell, or any chronic stigmata of the disease, and growth, the nutrition, and offer to plot the child on appropriate centiles, and then you proceed on with the examination. Suppose you identify this thing and you know you're sure what you're thinking of, don't jump directly examining at the face. Start with the hands. So what do you expect in the hands in this kind of condition?
Fine.
Yeah, that's fine. So a splenectomy has been done. You've got a hemolytic phases. So what are your differential diagnosis?
Thalassemia, most likely.
Okay.
Including thalassemia.
Yeah. Anything else? Yeah. Anything else? Yeah, but you have to provide a diagnosis which is the clinical reasoning domain, which should match all these findings. So they are not asking you differential diagnosis for splenectomy separately. They are not asking for hemolytic phases separately. They are asking it to be together. So, but I would slightly reorganize the order in here. So I would place the spherocytosis above the other things. This one comes on top of the list because you have the massive splenomegaly there, and when I indicated few scars in here, that was indicating towards laparoscopy surgery for gallstones removal. Okay, so splenomegaly, gallstones are classically seen in your HS. And then, so after surgery, what is there any specific things you would like to do?
We will like to immunize against against the what capsule bacteria, including pneumococcal, Haemophilus, meningococcal.
Yeah, so you will give pneumococcal,
influenza, and meningococcal.
And meningococcal, yeah.
In MRCPCH, right, this thalassemia case, this is most likely could be thalassemia case as well. So they have on their abdomen, they'll have so many dark pigmentation because of what do you say? Due to iron overload, chelation, they give desferrioxamine subcutaneous infusion, overnight infusion, and over a period of time, these children will have these dark pigmentations on their tummy. And such cases are very common in the UK. They are given subcutaneously infusion. Yeah, exactly. This picture, yes.
But in terms of abdominal distension, like how would you like kind of describe? Is it more of an upper or a lower one?
Lower.
Yeah. So then the questions again, your differential diagnosis should fit onto more of a lower distensions, and then there's also this area which is full. So what does that indicate? Then what would you consider in here?
Lymphoma.
Yeah. So this is quite straightforward. But again, without this, suppose if this was not present, so obvious, your again discussion will go towards your hepatosplenomegaly. So this is, I mean, this is just a small mnemonic. You can go through Mark and Beatty's book as well. It is better to group the causes and try to give your list based on all disease, autoimmune, hepatitis, and then R is reticuloendothelial cell, which is Hodgkin's and non-Hodgkin's lymphoma, and the T stands for tumor, which can be hamartoma. Yeah, I'm talking about isolated splenomegaly.
Yeah, so isolated splenomegaly, hematological, infectious, and then um storage.
Because at the end of the day, we can get confused with the mnemonics. So you have connective tissue disorders, but if it helps some guys, then that's fine. Connective tissue, you have SLE and SOGIA, which we discussed, which is leukemia or lymphoma. And this is specifically portal hypertension, which is extrahepatic or hepatic or suprahepatic. And then your storage disorders. So what can you make out?
This one has a fistula.
There's a transplanted renal the left islet fossa with a fistula on the right arm.
Yeah, perfect. So this is or either on this side, and this bulge is usually the transplanted kidney. And what you can see here, although it's an adult picture, but you might get even in a child, which is for chronic the dialysis catheter.
Familiarized with all these scars and catheters and things, and especially read about renal transplant. Tacrolimus, drugs used for post-immune suppression, transplant immune suppression.
Yeah. So they will ask you what would you like to do in terms of examination, and how will you manage if a child is coming with a post-renal transplant. You can also mention you would do a bedside renal calculation of the renal clearance, which is the Schwartz formula. Do you know the Schwartz formula? So it's a constant.
GFR.
Yeah, 0.43 multiplied by height multiplied by creatinine clearance in milligram per deciliter.
Yeah.
Or those things. And then failure.
Yeah, you have obstructive uropathy.
Yeah, obstructive, posterior urethral valve.
Either it's a posterior urethral valve or a stenosis of the pelvic PUJ junction, or abnormal ureters. Abnormal ureters causing reflux and your dilatation, and it has caused hydronephrosis and destroyed the kidney. Mainly any. So this is the blanket cause: obstructive uropathy, autoimmune causes like SLE, and your nephritis, which is the acute glomerulonephritis, which is the they can also ask you what are the complications post transplant. So what are the complications?
Yes.
I mean, obviously, I will put the first thing here. Apart from that, so if we just go through a few of them, so do you know what scar is this one for?
Liver transplant.
Yeah, so it's called Mercedes-Benz sign.
Yeah.
And then this scar.
This is also liver transplant scar is very common. Okay.
Yeah, you will be
this can be kept in this country. Yeah.
And then this one. So this is usually done for neck surgeries in younger children for laparotomy or a horizontal scar roofed in younger babies. And then you can have tiny scars here, which is a remnant of stoma closure. So a child with neck has this kind of scar, and they usually have a stoma formation. So later on, when the child grows, the neck is recovered. They close the stoma. The stoma leaves off a scar here, and then this scar is here. Okay, and then you can have appendicectomy scar lower in the groin area, as we mentioned, renal transplant scar. So yeah, I think, and then you can have posterior scars. You can also have, as I mentioned, we saw the spleen scar, the splenectomy scar, and you can have scars here for gallstones removal. Okay. So yeah, hopefully this should cover the abdominal station theory part and discussion for your station. But if you need any other specific ones that you would like to discuss, that's why I kept the history station as well in the abdominal section, so that we complete the abdomen today. And it should be done. And in terms of reading the theory, these are the main theory that you need to prepare. Is that all right?
Yeah.
Thank you.
Okay. So we'll if there's any questions, that's fine. Otherwise, we'll close the discussion.